Our today's topic is basics of pediatric orthosis. So, what is an orthosis? It's an external device with controlling forces to improve body alignment, improve function, immobilize the injured area, prevent or improve a deformity, protect a joint or limb, limit or reduce pain, or provide proprioceptive feedback. Orthoses are generally named for the part of the body they cover. Orthoses can be custom molded and custom fitted. Orthoses are classified as durable medical devices. So the next point is who is on the team. A team approach is always recommended for optimum outcomes. The rehabilitation team should include physician, orthotist, physical therapist, occupational therapist, social workers, and most importantly, the child and family. Physical therapists working with the child and family in schools and community rehabilitation settings play an integral role in developing the orthotic prescriptions. Diagnosis, prognosis, short term goal, long term goal, home environment, occupation, recreation, age, height, weight, and prior orthotic experiences should all be discussed among all the rehabilitation team members when determining which device are most appropriate for the child's current and future needs. Considerations include cost as well as adjustability of the device to meet the child's changing needs. Orthosis may be initially fabricated to provide maximum stability and then be adjusted for less stability and more voluntary control as the child progresses. Design and colors have greatly been improved, wearing adherence by allowing the child to personalize and have a choice in designing the orthosis, as we have wide variety of transfer papers now. Materials. There are numerous type and thickness of materials to choose from when fabricating an orthosis. Selection of brace, design, and the appropriate material and design of the brace is essential for function, strength, durability, flexibility, comfort, adjustability, compliancy, hygiene, and skin integrity. Most orthoses are made from vacuum molded thermoplastics, and the thickness of the plastics varies. Occasionally, metal and leather designs are appropriate. Carbon, graphite, acrylic resin will increase the strength and decrease the bulk of an AFO, but in Pakistan, we are currently not using carbon fiber or graphite AFOs. However, these materials are not as adjustable as thermoplastics. Coming toward the straps, strap design vary depending upon the need. Sheaf and loop design optimize stability, but dunning and duffing is difficult and have high bulk. Figure of 8 ankle straps have good control and the bulk is also moderate. Layover straps provide minimal stability and have minimal bulk. Straps help to align and hold the limb in the orthosis, and they have direct contact with the limb. Straps should fit securely and there should be no gap between the plastic orthosis and the child's limb. This increased stability and decrease unnecessary pressures. Now coming toward pads. Pads are often provided in the areas where there are bony prominences. They are used to support and cushion these areas of concern. Relief pads may be applied in an orthosis after fabrication or after physiological changes occur. The relief pads are applied to increase the 3.4 system in order to improve the alignment of orthosis. Pads should never be applied in an area of the brace that is already providing excessive pressure to the child. Even the softest padding will increase the pressure in this area. Trim lines. The length of the footplate of an orthosis may vary depending upon the child's need. Full length footplate to provide resistance to keep the knee from buckling, or with the utilization of a toe extensor pad for hypotonia, painful metatarsophalangeal joint, or if toes have a tendency to curl. Trimming the footplate to stop behind the toes is indicated to allow a normal third rocker MTP dorsiflexion and often allows easier shoe dunning. Trimming of the footplate to stop behind empty heads, rare in children, is indicated for painful empty heads. Full-length footplates may be designed with thin plastics, or the plastic may be thinned after fabrication to allow more dorsiflexion flexibility in the third rocker. Trim lines should optimize leverage for control without adding bulk to make clothing or shoe wear hard to fit over the device. What type of shoe should be worn with an orthosis? Shoes should have good construction, leather preferred, good heel contour, quality sole, a removable insole to increase instep depth. Heel height should be 1/4 to 3/8. Toes should be rockered. Laces or Velcro closure to instep. The fit of the shoe can affect orthotic function. The clinician can assist the child and family in selecting the proper shoe for prescribed orthosis. The heel height of the shoe can affect the child's standing alignment while in the brace. So the next question is, can an orthosis be used for contracture prevention or contracture reduction in children? Dynamic assistive braces have an adjustable tension spring assistance mechanical joint to reduce or prevent anatomical joint contracture. Static progressive braces hold a stretch with the force applied to anatomical joint. Increased range may be achieved with the increased manual stretch. Static braces have no adjustability and hold the limb in one position. Custom-made braces provide optimal control in all three planes of motion. These are indicated for long-term implications and multiplane control. Off-the-shelf braces provide adequate control in one plane of motion. They are option of purchase or rental for some braces. They are durable than custom-made and indicated for acute condition of limited range of motion. Acute conditions with soft end ranges and good skin integrity benefit from the off-the-shelf style. Chronic condition or certain situations like spasticity, soft to hard ranges, good to poor skin integrity, a child who has period of being agitated should be fitted with custom braces. The cost advantage is beneficial in these situations compared to multiple serial cast. Other interventions for control also should be considered. Other interventions like serial casting, antispasticity medications, and electrical stimulations. So this is all for today. Stay tuned for our next video.